right, let's start with the programming now. Our first presenter will share the latest research findings on the mechanisms of long COVID that can guide safe rehabilitation interventions. Our keynote speaker is the Director of Rehabilitation Innovation for the Mount Sinai Health System and Associate Professor of Rehabilitation and Human Performance at the Icahn School of Medicine at Mount Sinai in the United States. You can also find him conducting and directing research at the Abilities Research Center at Mount Sinai Health System as well. And checks notes. He's also my boss. So I hope you liked his introduction. Please welcome Dr. David Putrino.
Thank you so much, Jimmy. Absolute honor to be here today. I'd like to thank everyone at Long COVID Physio for inviting me to be here and to have this opportunity to take part in this conference that is just doing so much good. I am going to go ahead and turn off my closed captions for PowerPoint just so that there's not dueling closed caption experiences going on here. And yes, today I'm going to talk a little bit about what we currently know about long COVID from a pathological standpoint, how we can build that into making better care plans and making better research for people who are living with long COVID, and how this all fits into the universe of complex chronic illness that we're all collectively learning about together. So I'll just start by saying that I have nothing to disclose in terms of financial conflicts of interest. I think that is an important thing to state. And from there, we can just move into a bit of an overview of the three things that I'll be talking about today. The first is going to be targeted more toward clinicians and about how to be a better clinical provider for people with long COVID and other infection-associated illnesses. Then we'll talk about the pathology of long COVID. So how we might be starting to close the gap about lining up physical biology that is occurring in people with symptoms that people are reporting. And then I just want to do a little bit of a future talk about what we hope to be achieving next in our long COVID research initiatives. So let's start off with, how we can be clinicians, such as myself, such as many of the people I know are in the audience, how we can be better allies for people with long COVID. I think the first thing we need to know, and I'm sorry, this is probably going to be the wordiest slide that we have today, but know what you're diagnosing is the first thing that I think is just incredibly important. What I'm placing here are the World Health Organization diagnostic criteria for long COVID. You don't need to read all of these words, but effectively what this is saying is to clinicians, if someone is experiencing persisting symptoms after an acute COVID infection, and those persisting symptoms are not logically related to previous health issues that they had, then they probably have long COVID. And although these long COVID symptoms can wane and wax, so they can fluctuate, they can go away, and they can come back. Right now, we're not putting a time limit on the length of symptoms that people are experiencing because we know that these symptoms can be relapsing and remitting, and we just need to make sure that people get the care that they need. So as we start thinking about a long COVID diagnosis, the World Health Organization and the CDC did a good thing in making a very broad definition of long COVID or PASC. I think that the World Health Organization called it a post-COVID condition. The CDC and the NIH came up with post-acute sequelae of COVID, PASC. And I think what we all need to do is we need to understand that there is nuance to this as clinicians. So we need to understand that under this umbrella of anybody who got acute COVID, who is experiencing persistent symptoms, there is a group of individuals who have overt organ damage that lines up perfectly with the symptoms that they're experiencing. They have cardiac symptoms, and when you scan their heart, you see pericarditis, and that is something you can treat. They have shortness of breath, and when you scan their lungs, you see their lungs have been damaged by a COVID pneumonia. That is something that we know how to treat. On the other hand, there are individuals who are experiencing persistent symptoms that present as part of a syndrome. So we are seeing post-viral autoimmunity. We're seeing post-viral dysautonomia. We're seeing myalgic encephalomyelitis. We now have literature to support the fact that 50% of people with long COVID meet diagnostic criteria for myalgic encephalomyelitis. So these are things that we need to take into account as we're thinking about how to categorize individuals who meet a loose clinical diagnostic criteria for PASC, and understand that this may be a controversial statement, but I'm going to make it anyway because I think that there is a lot of messiness around the diagnosis of long COVID. PASC does not always mean the same as long COVID. I think that you can have explicit organ damage and a single organ being damaged by your acute COVID infection, which by criteria still meets the criteria for a PASC diagnosis according to the CDC, and it still meets criteria for a post-COVID condition according to the World Health Organization. But it is not the same as what many people have been experiencing for years now after their acute COVID infection went away, and they're still experiencing extraordinarily debilitating symptoms that do not show up on conventional testing as abnormal. So this is something that a concept that I hope that many can take away as clinicians. And I think the next step is, okay, well, then how do you diagnose this entity of long COVID? Well, first of all, don't think about it as a diagnosis of exclusion. Don't think I need to rule everything out before I give someone a diagnosis of long COVID. Of course, I'm telling you to take someone's past medical history into account, but also understand that timing matters. If someone has 5 different comorbidities, such as depression, such as diabetes, such as chronic lung disease like COPD, but suddenly after COVID, everything got much, much worse and new symptoms emerged, that is long COVID. That is not, just their comorbidities and an expected a consequence of their comorbidities. When you're seeing the timing of the emergence of the symptoms matters. And that is one of the biggest mistakes that I see, is a willingness to write off all of these symptoms because of some past medical history that would never cause this level of severity, and prior to COVID was not causing this level of severity, and suddenly it is, and suddenly we've got these incredibly debilitating symptoms. So as a clinician, please, if your patient says, I've been controlling my diabetes or my depression or my COPD or my heart disease just fine for 20 years, and now after COVID, I can no longer function, please understand that that is long COVID. Please understand that that is not expected for their chronic illness. Obviously, listen. We, as clinicians, we want to see diagnostic tests on a piece of paper, but understand that the CDC and the World Health Organization are encouraging a clinical diagnosis, not one based on lab results. So do not be afraid to make that clinical diagnosis. We are all skilled clinicians. If patients come and report the symptoms that we now know are familiar to us as long COVID symptoms, make the diagnosis. And then finally, understand that you can measure the symptoms that people are reporting, and you can measure them objectively, which brings me to the next concept, which is if someone comes to you with a symptom like fatigue, measure it. Don't just write down, my patient says that they have fatigue. We have shown in multiple studies now that individuals with long COVID will score significantly differently to individuals who claim to have fully recovered from COVID on very well validated scores like the fatigue severity scale, like the neuro quality of life scale, which measures cognitive impairment, and health-related quality of life scales like the EQ-5D-5L. These are objective scales that, by the way, are validated by the CDC and the FDA to be used in drug clinical trials because they're very good at capturing change in function as a result of chronic illness. So I urge clinicians to use these scales to measure things that we would usually think of as subjective, because measuring these things objectively can be the difference between one of your patients getting insurance and disability coverage or being declined. We have seen this over and over again, that when an insurer argues with us or challenges, how do we know that you're making a difference in the patient? If you are not measuring these subjective symptoms, all you have are your subjective notes saying patient complains of fatigue, patient is complaining of less fatigue. But that doesn't really impress anybody who is looking to, unfortunately, save a dollar. However, when someone asks you, how do you know you're making a difference? You say, well, when this patient came into me, they reported that their fatigue was a 78 on the fatigue severity scale, and now it's a 40 on the fatigue severity scale. Their fatigue has halved in 6 weeks of care. That is important for an insurer to make a decision, and it is hard for them to argue when you're using a well-validated clinical scale. So I really want to make this point. Final concept is we need to treat outside of the box as clinicians. So we need to understand that when you're treating complex chronic illness, we are treating very differently to the way that we treat non-complex illnesses. So although treating illness is never easy or simple, oftentimes it is very direct. You make a diagnosis, you send someone to specialty care, they get the best, appropriate treatment for that particular diagnosis at that time. And usually symptoms resolve. Complex illness is very, very different. And I was having a conversation with an ME/CFS doctor in Australia, Mark Donohoe. So I want to actually thank him for this analogy or metaphor, because I really, really liked it. When you're dealing with a complex illness, you're dealing with multiple problems all at once, and no single specialty is going to be perfect for dealing with this issue. And so one of the things that I think clinicians need to hear is, first of all, you need to be up to date with the relevant literature at all times. I know this is hard. I know this is a big ask of us healthcare workers after everything that we've already been through, but it needs to happen to effectively treat the people who are coming to us for care. And it's a really good way of thinking about this is thinking about a ship with a lot of anchors weighing it down. If you go to one specialty and you say, okay, I think my long COVID is because of viral persistence, and you're fortunate enough to have a specialist who believes you, and they say, okay, let's try antivirals, and you pull up that anchor and the ship still doesn't move. Let me ask you, would you throw that anchor back in before you try to treat the vascular pathology or the mitochondrial dysfunction? Or do you keep that anchor up and then try and treat the vascular pathology? And you pull that anchor up and still the ship isn't moving. Do you throw both of the anchors back in? Of course not. You try to pull the last anchor up. And what we're seeing more and more is that people with long COVID and other complex chronic illnesses, they have 6, 7, 8, 9, 10 anchors in the water. And what we need is an integrative approach where clinicians are interacting with one another, and not saying, well, we tried the cardiology route, that didn't work, so let's stop all the medications there and now try the gastroenterology route or the physical therapy route or the psychology route. That is not the right approach for complex chronic illness, and we need to change our opinions quickly. So I got to keep moving because we've got limited time. But now I want to move into a description of the pathology of long COVID and how we're trying to line up biology with symptoms. Our goal here is to move toward diagnostic biomarkers so that we can do a lab test-based diagnosis of long COVID. And also, once we understand what's happening on a pathobiological level, it also gives us treatment targets for people with long COVID that we can start trying from a medication standpoint. So I'm going to share some research that is currently under review that I hope to be published soon. But it was a real group effort from hundreds of really phenomenal scientists that I just feel very fortunate to get to work with every day. And the first step was putting out 3 groups. We started off with a group of people with long COVID, then a group of people who we called the convalescent COVID group. This was a group of individuals who had a COVID infection, but felt as though they were fully recovered from that COVID infection. And then we had a COVID naive group. This was a group of individuals who had never had a COVID infection. And we confirmed that with ultimately with a blood test. We then did a detailed logging out of everybody's symptoms. So we understood who had all of the different common symptoms of long COVID. We measured those objectively with our clinical scales. And we did this in everybody, not just the people with long COVID, but also the individuals who had never been infected or claimed to have fully recovered from their long COVID, so that we had a detailed database of everybody's relative levels of fatigue and cognitive impairment and post-exertional malaise and so on and so forth. We were then, like I said, this is just a small sampling of all of the incredible people who worked on this project, but we were fortunate enough to have just a world-class team of excellent scientists looking at this data and doing some modeling. And we made some findings. The first thing that we showed, and in and of itself, this is not an incredible finding, and this will make everyone roll their eyes and say, well, thanks. But we will come back to this finding. The first finding that I thought was incredibly important was we could, with 94% accuracy, differentiate people with long COVID from people who do not have long COVID, just based on the symptoms that people were reporting. So meaning that if someone comes in and tells you all of these symptoms, that is an accurate way to classify and make a clinical diagnosis of long COVID, because people without long COVID don't report those symptoms. So like I said, this is somewhat of an obvious finding, but it will become more important as we go through the different findings. We also showed that people with long COVID, not everyone with long COVID, but a large and significantly different proportion of people with long COVID had significantly elevated proportions of activated T cells, both CD4 and CD8. I know that this is can sound like just random word salad to a lot of people. Immunology certainly sounds like that to me. What this means is that the bodies of people with long COVID, the immune systems of people with long COVID, are actively fighting something, as opposed to the immune systems of people without long COVID. So this was hard evidence that many folks with long COVID have an immune system that is currently under siege. Their T cells are activated, meaning that they're out there fighting things. In that vein, we also found that people with long COVID had a recent reactivation of different viruses, primarily herpes viruses such as Epstein-Barr virus. So not only were these individuals actively fighting something, but some of the dormant viruses in their system had recently been reactivated. Another finding that we made that I think is something that we need to explore more deeply, but was a striking differentiator, was that the presence of a substance in our body called cortisol, which is usually something that we use to wake ourselves up and sort of bring systems online when we wake up in the morning. We saw significantly reduced morning cortisol in people with long COVID versus the two subgroups of people without long COVID. The COVID recovered group, which you can see here, somewhat straddling the two groups, which is a little concerning, and the COVID naive group, the group that had never had COVID. So this was also a very interesting finding, which might lead us toward a potential test for long COVID in the future. But for right now, this is a preliminary finding that we hope to study more deeply. So this leads us, all of these other immune findings and hard objective findings lead us to something that was very important. Based on all the lab tests we took, if we took all of the lab tests and we built them into a model and we tried to classify long COVID and not long COVID, we had a 96% accuracy in classifying long COVID, not long COVID, based on an aggregate of these lab tests. Very important because this is taking us toward a diagnostic biomarker. What you can see here, and I know that this is being recorded, so we won't spend much time because I know I'm running out of it. But what you can see here, is, if you go back, is all of the things that we were testing for and all of the things that in your blood will be higher in people with long COVID on the right and lower in people in long COVID on the left. So for instance, like we said earlier, morning cortisol was much, much lower in folks with long COVID compared to folks without long COVID. Whereas EBV activation, Epstein-Barr virus activation, was much higher. So this is what this particular graph means. So I wanted to share that. Finally, the last thing I want to share, because, and this relates back to the first finding, is that we said, okay, well, we can classify with 96% accuracy who has long COVID based on their lab tests. And we can classify with 94% accuracy who has long COVID just based on their subjectively reported symptoms. How often, we ask the question, how often do the cases that our algorithm selects as a long COVID case based on what the patient is telling us, the symptom score, how often does that overlap with the cases of long COVID that our algorithm is selecting based on the lab tests? And the answer was there was near perfect agreement, which you rarely see. Cohen's kappa is an example, is a measure that we use to see agreement between two different ways of classifying something, and you rarely see a near perfect agreement. What we saw here was a near perfect agreement in the classification strategies, meaning that the people who were reporting those subjective symptoms were the same people who had the abnormal lab tests in our classification algorithms. So once again, clinicians, if you're still listening, believe your patients. Clinical diagnosis is more than sufficient for right now. So in the last 5 minutes, I just want to talk about what is next for long COVID and other complex chronic illnesses for us and what we're researching. And 3 major steps here. We need better characterization of symptoms. And that's where we're going to start now, because I really need to point out that even though I've been advocating for using patient-reported outcomes to classify things like fatigue, long COVID symptoms and complex chronic illness symptoms have nuance. So these sleepiness, fatigue, exertional intolerance, post-exertional malaise are all things that are commonly lumped under the fatigue umbrella. And let me push this even further. Fatigue often has different qualities and different forms. And currently, in our lab, we are not differentiating between these different forms and different qualities of fatigues because we do not have the instruments to separate them out. So a lot of our research is going to focus on separating out different types of fatigue because different types of fatigue and other symptoms, because different types of fatigue, cognitive impairment, post-exertional malaise, shortness of breath will have different underlying causes and therefore require different treatments. And you will not be able to effectively treat one sort of fatigue with one intervention and the other. This is what we mean by precision medicine when we talk about that term. And without really zeroing in on these symptoms the way that is not being done right now, we're not going to have precision medicine treatments for long COVID or other complex chronic illnesses. Next is research to understand our neighbors. When I talk about neighbors, I mean all of these other complex chronic illnesses. So our next step with the work that we're doing with Akiko Iwasaki that I just presented was adding other people with infection-associated chronic diseases and complex chronic illnesses into the mix to see how the folks with long COVID vary or have similar blood findings to people with ME/CFS, Ehlers-Danlos syndrome, multiple sclerosis, PANS/PANDAS in kids with long COVID, and Lyme disease, and many, many others. Because we now understand how long COVID looks different from healthy, but we still don't know how long COVID looks different or the same from individuals who have other complex chronic illnesses. And our final sort of point of the triangle here is rapid interventional clinical trials. I know that people in the long COVID community have been screaming for interventional clinical trials beyond symptom management for a long time. So we're getting there. So I'm really proud to announce that just 2 days ago, a group that I'm proudly affiliated with, the Long COVID Research Initiative, just received an initial grant of $15 million to do rapid, active, impact-oriented research. We have a patient advisory board made up of individuals with ME/CFS and long COVID and other infection-associated chronic illnesses. We have an incredible trials group from institutions all over the country and all over the world who are expert in post-viral illness and running pragmatic, rapid clinical trials. And the goal is to rapidly try out interventions, drug-based interventions that can move the needle on what we're seeing from the basic science work, such as what we're doing with Akiko and other partners around the world and the country. So please don't give up hope. We have a lot of really rapid interventional research coming. Our plan is to select clinics all over the world to then take on, rapidly adopt the findings of these clinical trials as soon as we complete the relevant studies so that people can get treatment as soon as possible. So I had a lot to cover, but I hope I've left you on a very, very hopeful note that more great interventional research is coming. I just want to state that nothing I do happens in a vacuum. So many people have contributed to this. I just get to be the lucky person to talk about it. Thank you, everyone, for listening, and I will hand back to Jimmy.
David, before you go, there were some questions, a lot of questions, but honestly, a lot more discussion in the chat. But there was one that I know, David, that you're pretty passionate about. We've got about 60 seconds. Okay. Suggestions for patients whose physicians, PTs, other healthcare providers don't believe them. I know that you and I have talked about this a lot. This feels a lot like the term gaslighting, which came up a few times yesterday. In a minute or less, what suggestions would you give for this situation?
In a minute or less, and yeah, this is a talk all on its own, but in a minute or less, if you're not being believed by your clinician and it is not feasible for you to find another clinician in your area, I think the simple checklist you can take your clinician through is, okay, if you don't believe that my symptoms are being caused by long COVID, can you please tell me what other things could be causing these symptoms? And more often than not, you've got heart palpitations, so it could be a heart problem. You've got shortness of breath, could be a lung problem. Okay, what steps have you taken to rule out these other diagnoses? And then what is the most negative thing that could happen if you have not ruled out these diagnoses? So if you've got heart palpitations and you've got a latent heart condition, well, the worst thing that can happen is you could have a cardiac event. So hopefully, and with this line of questioning, the hope is that you are leading your clinical provider to the realization of, oh dear, I haven't ruled out anything. I'm just using my subjective opinion to say that this person is faking. And if I don't rule these things out and they do have a cardiac event, I could be in quite a bit of trouble. And that is usually the beginning of the conversation to get the person to take you seriously, to get the person to run the tests that are needed, and then get you on a clinical path toward ruling out some things, ruling in some things, and getting actionable